Thanks a lot for inviting me to talk today. My talk is called Setting Up a Participatory Cohort Study in PCD, and I'm going to talk about experiences and give some results from the COVID-PCD study. Right, just to give you an idea of what I'm going to talk about, first a bit about why the study was set up. Then I'm going to talk about the methodology and all the bias, so everything that can go wrong during the setup of the study, and in particular the COVID-PCD study. And then I'm going to give some new results from the study. I included a few questions, so be ready to push some polls. So how was the study initiated? There was, at the early period of the pandemic, so back in February, March 2020, Claudia Kuehni was approached by a person with PCD who had very good contacts to the PCD network, and asked if we shouldn't set up a study COVID-PCD or COVID-19 in people with PCD. Claudia said, that's a great idea, let's do it. So we did that, and we from the beginning decided that it should be a participatory study. So done in very close collaboration with people who have PCD or are in the PCD network. So had, for example, a child with PCD. And we from the beginning set up a group of people with representatives from different PCD support groups all over the world. You see them here on the right. So from the US, from Germany, Switzerland, UK, Australia, Spain, Italy, and France. And we then had discussions how to set up and how it should be designed and why, and so on. Just for those of you who might not have so much experience with what participatory research is, you can think of it as like co-ownership of the study. So it's not just researchers studying some research question in a population of people who have a certain disease, but the people who have the disease really are part of setting up the study and part of deciding how it should look and why, and so on. So we first had discussed the idea for the study, of course. Then we set up a patient advisory group so that we could keep discussing. And then we discussed the vision, and we then implemented the ideas. We went back to discussion how, and then again implementation. So it's really an iterative process of discussing and implementing when we did this study. So both at the beginning, but also throughout the study conduct. Just to remind you of the context. So here is a timeline of the pandemic and how it looked or developed in Switzerland. And we set up the study back here in early 2020. And that was actually at the time when the first wave was slowly slowing down. So we, of course, didn't know what would happen after. And we already thought, oh no, we are already too late. So it's for you to have in mind that we were under time pressure to set up fast, but of course also to keep the quality good of this epidemiological study. The aims in the study design. So from the beginning, we had two major aims of this study. So the first was, of course, to study SARS-CoV-2 and COVID-19 in people with PCD, but also to get more information about PCD in general. We knew that we would get a lot of information directly from the participants, so that was from the beginning also an aim. The study design is an international participatory cohort study where we collect data using online questionnaires. In the beginning, we had a lot of discussion with whether it should be an anonymous study or a non-anonymous study. If it was to be an anonymous study, so where we would collect personal information, for example, name and birth date, the advantage would be that we would be able to validate the information. For example, if a person got COVID, we would be able to link to the hospital record and then get further information about what would happen to this person. That would, of course, be very helpful to study severity and whatever would happen. However, the disadvantage of a non-anonymous study would be that it would be complicated ethics and possibly also less participants. So yeah, you might be less likely to participate in a study where you would give personal information to a study where you don't necessarily know who set it up. Again, the advantages of an anonymous study would be more people might participate, while the disadvantage would be that we couldn't then validate the information. So here comes the first poll, and maybe Yinting need to start it. If you were to choose, would you set up this study as an anonymous study or a non-anonymous study? And yeah, just give your best shot. There is no right or wrong answer. I don't know if we can see when people have participated. But maybe we just try to say share results. Or am I supposed to do that? I'll try. No?
Sorry, no, it couldn't start.
It couldn't start. Okay, whatever, it's fine. We just close this one. So just think about it. Or maybe try, can you see this one? Maybe you can try. Yay, fantastic. It works. All right. I think everybody of those who wanted. So most say anonymous, but there's also quite a lot who say, or there are 30% that say non-anonymous. Thanks a lot. So, right. We decided to set it up as an anonymous study because of different reasons. So first was that most of the patient representatives prefer this version because it would be more people would probably participate in the study this way, and we agreed. Also, for this particular study, total sample size would be crucial. So if we wanted to study, for example, severity of infections, we would need a certain amount of infections to even be able to study this. So that's why sample size was very important for this decision as well. Also, actually to link the objective data would be complicated, especially when we're sitting here in Switzerland, everything is going on online, and we would need to link to some hospital in some country, and it would be very difficult. So that's also one of the reasons that we said, no, let's do an anonymous study. Okay, second poll. Let's see if this one works. Yay. By designing it as an anonymous study, which type of validity did we most probably improve? And the answer categories are internal validity or external validity. Just give a few more seconds for anybody to answer if anybody wants to. Otherwise, we continue. So yeah, it's half-half, more or less. Oops. So half-half, internally and externally. So most probably we improve the external validity by making it an anonymous study. We can also discuss whether we improve the internal, that's also possible, but at least for sure the external validity. So just to remind again, the internal validity has to do with the quality of the data or the quality of the study as you set it up. So within this study population, how much do you trust the results that you get out? Whereas external validity is how much do we think that the results that we find in this study population represent the target population, which in this case were people with PCD in general. And if we think that people were more likely to participate if it's an anonymous study, then we hope that the representatives or representativeness of our study is better than if we had made it non-anonymous. Right, ethics. We decided to get ethics, so apply for ethics. We might not necessarily have needed it, but one thing is that we collect, of course, email addresses. However, not all people have their name in the email address, but quite a lot do. So we actually do have some personal information from several of the participants, maybe somewhere around half even. So it is really important to keep this confidential and be careful also with everything that has to do with data security. Also, if we have ethics for a study like this, we have higher credibility. And of course, also for publications, it can be very hard to publish anything if you don't have an ethical approval. So we sent an ethical, application to the ethics committee in the canton of Bern, so here in Switzerland. And because it's considered a single center, because the database is here in Switzerland and everything is online, all data is entered by participants themselves, we don't need ethics from anywhere else. We got provisional ethics approval in mid-April and the final approval in June. And it went really fast because of the pandemic. So the ethics committee prioritized all studies that had to do with COVID-19. So that was really lucky for us. Then we had to find out how could people then actually participate. And because it's an online study, we decided that it could happen via a website. That's the obvious, I guess. Other things would be letter or, yeah, but we decided for a website and it's been very helpful and it's been set up then from the beginning. And you see here the big red button, that is the button to participate in the study. When a participant pushes this button, it leads the person straight into our database. And it has worked quite well. And the more languages we included, of course, then we also included these languages on the website. It includes general information about the study, information about us, also study results, information about publications, and yeah, everything. Also contact information so that participants could contact us. Recruitment. We also discussed this quite a lot, but we decided that the recruitment should really go through the PCD support groups and PCD networks, because that's where it would be possible to actually reach the participants. So we decided from the beginning that we ourselves couldn't do much, but that the support groups should try to reach and advertise. And they did that really fantastically through emails, through social media, through internal networks. And then, of course, they linked to the website that people could then participate. Data collection. So which and how many questionnaires did we decide on? So here I'm just trying to show a bit the structure of the study. On the far left, you see that at the beginning, participants register, and that happened through this website. They then have to give information about the birth year so that we could make sure that we sent the correct questionnaire. So the adult questionnaire to adults and adolescent questionnaire to adolescent and so on. For children at the age of or until the age of 14, parents completed the questionnaires. So after registration, where they also gave an email address, they received the baseline questionnaire straight away through an email link. And then 7 days after completing the baseline questionnaire, they would receive the first online follow-up questionnaire. So the follow-up questionnaire was sent out once every 7 days, depending on the baseline date. So when the person completed the baseline questionnaire. The third type of questionnaire was extra questionnaires that would then focus on a special topic. They would be sent out at whatever time point we had ready to everybody at the same time. Until now, we sent out 2, one focused on face masks and one focused on COVID-19 vaccinations. So the content of these different questionnaires, the baseline was quite an extensive questionnaire with information about prior infection with SARS-CoV-2 and COVID-19 illness. Quite a lot of questions about PCD diagnosis, clinical characteristics, typical symptoms, environment and lifestyle. The follow-up questionnaire was or is quite short and has questions on newly happened SARS-CoV-2 infections and COVID-19 disease, regular symptoms, social contacts, and lifestyle. And then again, these extra questionnaires, which are on special topics. Okay, so we now talked about questionnaires. So here comes the next poll. Yeah. What types of biases can arise when using self-reported questionnaires to collect data? And here you can tick multiple choices. The first choice is selection bias. The next choice is non-differential misclassification. And the non-differential refers to like random errors that can happen across the whole population and doesn't necessarily depend on whether you have a disease or not a disease. The third option is differential misclassification. Oh no, you can't see it. Due to recall bias. Differential here means that it might be different in those who have a disease compared to those who do not have a disease. So more errors in one group compared to another. Then we have differential misclassification due to interviewer bias, differential misclassification due to differences in the quality of information. Here you can guess or you can put whatever you want and then we discuss it. It's just for you to think a bit. I'll leave it a few more seconds. Right. I think that's more or less it. So yeah, a bit more than half say selection bias, a bit less than half says non-differential misclassification, differential due to recall bias. Most people say that, a little bit less for interview bias, and almost all for the last one, differential misclassification due to difference in quality of information. Right, thanks a lot. Oops. Okay, so selection bias, yes, that can happen. Non-differential misclassification, yes, that can happen. Differential misclassification due to recall bias, yes, but depending. Differential misclassification due to interviewer bias, no, because they're self-reported. So there is no interviewer that can load a question differently depending on whether a person has certain characteristics. So that's at least one good thing. And the final one, differential misclassification due to differences in the quality of information, also not, because everybody receives the same questionnaire independent of whether, for example, they had COVID or not. So most information that we collect, it's same for everybody. This type of bias is often seen in, for example, studies where we collect information from medical records, and it might be that medical records are more complete if a person had a certain disease compared to those who did not. So there the quality of the information would be higher. So luckily, that's not a problem here. But for the others, the selection bias, that can occur if subgroups of participants are more likely to answer certain questions. So for example, we can imagine that maybe highly educated are more likely to answer a certain question or to answer correctly compared to people with less high level of education. Might be the same for females and males, and younger and older persons. So that is important to have in mind, that even selection bias can happen at the time of collecting data. Even when you have already designed your study, this kind of bias can still happen. How to prevent it or reduce it? Prevention is probably a bit difficult in these kind of studies, but we can use validated questions. So they have been tested and hopefully know to a certain extent where there might be differences, for example, subgroup differences, and you can try to make questions where that's minimized. And you can keep the difficulty of the questions low so that you are pretty sure that you get the same quality of information across these subgroups. For the COVID-PCD study, so for some of the questions that we have, we use the follow PCD, which is a standardized form for collecting information about symptoms in people with PCD, and it has been tested and it's now used in different studies. For questions where there were no existing questions, we made sure to, for example, include explanatory text where if it was a difficult concept that we asked about. We also left out some important questions if they would be too difficult to answer. For example, in PCD, of course, diagnostic information is very important, but it is quite likely that few people would be able to answer the results of a TEM analysis, other than, for example, it was typical for PCD. The specific defect, they would probably not know. So it doesn't make sense to include a question like that. And of course, in the development of the study, so in the beginning, we had lots of discussion with patient representatives and also experts about how to formulate certain questions. We, of course, or unfortunately, didn't have time enough for full validation due to the COVID-19 pandemic situation. So again, as in the slide in the beginning, we were under time pressure to even start the study before the pandemic was over. It, of course, wasn't, but we didn't know that at the time. Non-differential misclassification can occur due to typos. So people just put the wrong button. Random recall problems. So I can't remember what I did last week for this and this thing. It can happen to anybody, not necessarily depending on subgroup, perhaps depending on subgroup, and random misunderstandings of questions. So how can we prevent this? One is to use, for example, branching logic to make sure that a person doesn't complete a question that it shouldn't have just because it didn't know that it should jump. So that's one thing to try to control, that you get good quality data. And again, as for the one before, use validated questions and keep the difficulty of the questions low, so you minimize the risk of mistakes. Differential misclassification due to recall bias can occur when a participant remembers exposures depending on an outcome. So for example, if a person had COVID, they might be more likely to remember certain things that happened in the past because they had an infection. Whereas those who didn't have COVID might not even have thought about whether they had a certain symptoms or a certain problem. So that's where this recall bias come in. How can you prevent it? You can use a prospective design. So you make sure that the exposure is collected before the event happens. So in this case, you collect information, for example, from the baseline questionnaire before a person experiences SARS-CoV-2 infection. And specifically for the COVID-PCD study, this type of bias is relatively low risk, except for those people who reported a SARS-CoV-2 infection at the baseline, in the baseline questionnaire. There, they might be more likely to remember symptoms in the past 3 months a bit differently than those who did not write or report an infection in the baseline. However, all the infections that were reported in the follow-up questionnaires, there's no way that we could have recall bias. Right, and just in PCD, again, information about diagnosis and diagnostic tests is, of course, very important. And that is, to a certain extent, a limitation of our study, that we could, of course, collect as much information as people would know. But there are certain things that people just do not know and cannot answer in a questionnaire study. However, we limited, again, the questions to what people most probably would know, and we still have good information about whether they had tests done and whether they were typical for PCD or not. Right, database. So when you do a questionnaire study like this, you of course need a database. We chose to use REDCap. It's quite a flexible program. You see, I just took a snapshot of the database overview, and we have the different forms here on the left, the number of variables. You can choose what you want to do. You can copy instruments, you can delete them, and so on. You can set them up as a survey, which we did, and you can program how often they're sent out or not sent out. It's really quite easy to use, so it's quite user-friendly. When you have to do different languages, it's sometimes a bit difficult. We started with English and German in the same database, but realized that as more languages get on, the data just explodes. So we then set up a new database for each language and then merge at the end. And it worked quite well. However, I think now REDCap developed new functions for different languages. So in case anybody needs it, I think there are new functions which makes it a bit easier to use different languages. Of course, bias can also happen when you translate to other languages. It's called detection bias due to differences in terms used in different languages. How can you prevent it? Do both a translation and a back translation. In COVID-PCD, we had a back translation for some of the questions, but most we didn't, especially those that were about SARS-CoV-2 infections or COVID-19. However, to our luck, we were studying a concept which was so much up in the media that we were pretty sure that most people would know if they had a test and even what type of test it was. So people had heard so much about this infection, which actually was our luck, so that we were pretty sure that people would know about it. If you study something that few people know, then you would need a lot more explanation text for people to understand and answer correctly. Right. And just again, so throughout the whole study, it's really been a process where we continuously got feedback, both through discussions in this patient advisory group, but also through emails, comments in the questionnaires, and so on, where we have then implemented in the study. So, for example, there were typos in the beginning in the questionnaires. We quickly fixed them, or, for example, when the booster came, we got quite a lot of emails saying, I can't enter the booster, so we hurried up and put that in. Or there were discussion about, for example, communication, persons who wanted to know more about certain results. So we really tried to implement the feedback that we got to improve it. And now I'm going to talk a little bit about some results. Yesterday I downloaded the data, and we have 732 participants from 48 countries, and in total 7,903 questionnaires, and a bit more actually, because I forgot some. But it's really quite impressive, both how many people participated and are still participating, and how many people have continuously completed these questionnaires throughout the study period. That's really fantastic. In the figure here, you see the red line. That's the cumulative participation, which of course went steadily up in the first year, and then slowed down a bit in the second year. However, there are still new people who participate, which is really great. The blue bars are the number of people who completed the weekly questionnaires. And again, in the first year, it was stable around 250 per week, and then it went down slightly. As a consequence, here from end of December, we have reduced the weekly questionnaires to be sent out each once a month instead. So to lower the burden for participants, but because the wave is on its highest, we couldn't just stop them. From where do our participants come? You see here a map of the world. The orange colored countries are countries with less than 10 participants. We have quite a lot. Then we have the blue countries, which are countries with 10 to 50 participants, among others, Australia, Switzerland, Italy, France, Spain, Canada. And then we have the red countries with more than 50 participants. Also, almost all have more than 100. So from the US, Germany, and the UK. So it's really quite exciting that people come from so many places. And how many got COVID-19 is, I guess, the main question. And in this slide, you see the proportion of people who got who reported a positive test of SARS-CoV-2. So if you see the table on the left, it's by age group, and then the total in red. So here you see the number 222. That's the number of people who said that they have PCD. So there are 10 people who participated who don't think that they have PCD, but it's still fine. But we then have to exclude these from certain analysis. You see that there are most people in the younger age group, so 133 are less than 10 years, and then it goes steadily down, but we still have 46 people who are above the age of 60. And then you see on the right of that table, the SARS-CoV-2 cases, most in the younger. And then in total, we have 58 cases. The blue bars on the right shows the proportion, so the percent of people who had COVID-19 or SARS-CoV-2 within the age groups. And you see that the percent is highest among children 10 or children and adolescents 10 to 19 years, where it's almost 12%, and participants above the age of 60, where more than 12% had SARS-CoV-2. We can maybe again talk a little bit about selection bias. It might be that some people be more likely to participate in the study because they had COVID-19. And therefore, we did another analysis to study incidence. So there we looked at how many got SARS-CoV-2 during the follow-up. So we excluded participants who reported an infection in the baseline to actually reduce selection bias from people participating because they had an infection. And here we see that we had 38 incident infections, and in total 615 follow-up years So that's the complete time from baseline till the last follow-up questionnaire was completed. It, of course, gets bigger every week. And then we have the incidence rate, which was 6.2 per 100 person years. And now I'm not comparing here, but it's still quite a lot lower than in the general population. If we then look at the incidence in the age groups, we see that the incidence is highest among the 0 to 14-year-olds, where we saw 20 incident infections in 180 person years and an incidence rate of 11.1, where it was lowest in the middle-aged group, and in the oldest group, it wasn't as high as we only looked at the proportions. So it does look as if there might be some sort of selection bias here. But at least we can take that into consideration when we look at only follow-up time and incident infections. Self-reported severity, so how ill did they get? You see two bar charts here on the right. The upper one is first infections, and then we saw also 3 reinfections, where we really also looked at that they had 30 days at least between the 2 infections, where they also had a negative test, and these infections were at least half a year apart anyway, so it's for sure reinfections. But of the first infections, around 20% had no symptoms, so were asymptomatic. Around half had mild symptoms. Mild symptoms were described as mild fever, a little bit of cough, a little bit of other symptoms. 22%, 15 people said that they had moderate symptoms, so high fever, lots of other symptoms, headache, cough, but were not treated at the hospital, so stayed at home. And 5 people in total were treated at the hospital. However, none were treated in intensive care, and the longest stay was 9 days. So overall, it looks as if it's relatively mild compared. What we see is that it looks as if the reinfections had worse symptoms than at the first infection. Here is a timeline of the reported SARS-CoV-2 infections. It goes from March 2020 to January 2022. And you see that there are quite few infections here in the first wave. But we also have to remember that testing opportunities were quite low, so it wasn't easy to get tested. So most probably we have missed some infections here. However, otherwise we see that the infections are similar to what we've seen. They follow the general waves. So fall 2020, we saw quite a lot of infections. Spring 2021 a bit, and then of course here fall 2021 and winter 2022 we also see quite a lot of infections. However, we've seen 1 person who had been hospitalized due to COVID here in December, which was also a reinfection, but otherwise all the hospitalizations were before all the vaccinations. Here, just the timeline with the reinfections. And the timeline with when taking vaccinations into consideration. So it's the same figure as before. The blue ones are unvaccinated children. At least for a long time, they were not even possible to get vaccinated. Then we have the unvaccinated adults in this light orange and vaccinated adults in dark orange. And after the vaccinations started, we mainly saw that those adults who got infected had already been vaccinated. And talking about vaccinations, we sent out this extra questionnaire in June 2021 and asked, among others, how many had been vaccinated. And here I show results for adults adolescents, and children. And if you look at the adults on the left, you see that 96% said that they had already been vaccinated or planned to be. And very few actually said that they did not plan to get vaccinated. Already, the adolescents, already 40% had been vaccinated at that time. And among children or parents, we asked if the vaccines would get approved, would they let their child get vaccinated? And more than 60% said yes. We also studied the speed of vaccination rollout by country, where we used date that was reported in the weekly follow-up questionnaires. And we showed by country. So if you look at the black line, which represent the UK, you see they were extremely fast. And already in mid-February, 80% of the study population had been vaccinated. The second fastest country, which was the United States, they had vaccinated 80% of their population in end of March, and most other countries had 80% vaccinated by start May. So we also saw quite a lot of differences in the speed of vaccination. We also looked at the incidence by vaccination status. So here you see 3 lines. You see the people who, or adults, where we had information about follow-up time, who had not been vaccinated, and it's the follow-up years. So it might be that a person dropped out of this or stopped filling in the questionnaires before vaccinations, so we wouldn't know whether this person would be vaccinated or not. But at least the person, now I think I'm saying something wrong, I'm so sorry. No, these are in the population where we had information about vaccination study status. So either they reported vaccinations in the baseline, in the follow-up, or in this special questionnaire. So in the not vaccinated, we saw an incidence rate per 100 person years of 14.3. Then in the vaccinated, but time before vaccination, we saw an incidence rate of 3.4. And then in the vaccinated, with time after vaccination, we saw an incidence rate of 7.7. Here it looks as if the not vaccinated had a lot higher incidence rate. However, we need to remember that it also includes children, where we overall saw a higher incidence. So it's a little bit hard to interpret these results. They're not adjusted for age, country, or waves. And that's our next task, to build a Cox regression so that we can take this into consideration and take the time varying exposures, such as, for example, waves, into consideration. I'm soon done. Self-reported severity by vaccination status. Here it looks as if unvaccinated adults more often reported moderate symptoms compared to vaccinated adults. I guess that is also what we would expect. However, it's not super striking. But again, we also didn't see a lot of really severe cases. So it's a little bit hard to judge with the data that we have. Yes, so we also wrote some publications, one that describes the study, one that describes SARS-CoV-2 infections, and one that focuses on face masks, and one that focuses on vaccinations. They're all linked in the website if anybody would be interested. However, we also send out results from the study through other channels. So to be able for participants to follow the results of the study, we did a weekly update of results on our website, where we gave information about participation, number of SARS-CoV-2 cases, severity of disease, and also vaccinations. And we've actually had quite good viewings of the results on the website. And we also had quite good recently feedback from participants who said it was interesting to follow the results, and that they were more likely to keep filling in the questionnaires because they could see what happened and what happened with the results. We also sent a newsletter in the summer, and we've had now, I think, 4 or 5 online meetings that were set up by the different PCD support groups. So we've had one with the US, we had one the UK, we had one German speaking, we had a Spanish speaking, we had a French speaking. Yeah, that's already 5. And that was really interesting, and we had good feedback and good discussions with participants and interested people. Yeah, with that, I'd like to say thanks a lot, really, to the participants and all the PCD support groups and the collaborators. That's been, yeah, people have been very engaged, and it's been great. The study is funded, of course, by different funders, and we're also part of the BEAT-PCD network. And of course, here in the research group, of course, we are certain people that have worked specifically on this study, but also got a lot of help from all the others. So also thanks to, yeah, Yinting, Christina, Rebecca, and Helen and Daria. So that's it from me. And if you have questions, I'm very happy to try to answer.
Thank you very much, Eva. That was a very excellent presentation.
Thanks.
And we have some comments and questions, right, Katie?
We do indeed. So if we kick off with a comment from Bernard, selection bias, more or less only people with PCD that are active in Facebook groups are reached. Do you have any thoughts on that?
Yes, that is a very good comment. I think we try to get as many people to participate as possible, but of course we have missed those who aren't very well connected to either PCD groups or, as Bernhard suggested, Facebook or somehow in some kind of network. And of course, there are many people with PCD that don't know other people with PCD because it's a rare disease. So for sure, already here, we also have a selection bias, but it's something that's very hard to do anything about. We did everything we could to try to reach as many support groups as we could. So we looked up in the internet, but again, that doesn't help those who are not connected to a support group.
That's true. And Mirona just commented that we also advertise the study through the treating physicians.
Yes. I believe the main recruitment has gone through PCD groups, but it might be that we reached a few through treating physicians. But that's my personal impression. Yeah.
Sure. And she adds that, but people who are not connected at all to a network cannot be reached, of course. Yes. Mm. Yeah.
So we now have a question from Matthew. How are you sure that people answering have PCD? Could anyone access the survey link?
Yes. So yeah, we discussed a lot in the beginning how we would do this. We ask about tests. So if people, so first we ask if they think they have PCD, and it was clear from the beginning that we wanted to include people even if they had suspected PCD. So we didn't want to exclude anyone who might not have a secure diagnosis, because in PCD, yeah, sometimes it's not even possible to get a definite diagnosis. But we included questions where we asked quite detailed information about, for example, did you have this kind of test done, and explained how the test is done and why you would do it. So to make sure that we at least hope that people would answer this correctly. However, of course, we can't say for sure if they have it, but those who say yes, they had a TEM which suggested PCD, and they had a low NO. We have quite a lot who give the specific genetic defect So we are pretty sure that they have PCD, but there are a certain amount where we can't know, and it's only, yeah, suspected.
The next question would be from Zina. How did you make sure the same person doesn't answer the survey more than once? Sorry, especially for adolescents or young adults who maybe the patient or the parent answered themselves.
There are, of course, limits to how much we can check, but what we did do was to check manually whether person with the same email address completed the questionnaire several times. However, of course, there might be parents who completed for children of different ages. So there we went in and looked also at country. If there's information about region, we would look at region, and age or birth year, because we didn't ask birth date, but birth year of the person. And we did identify a few where it really looked as if they had completed the baseline more than once. And then we decided to take the first, but it's quite few, maybe in total 5 or something like that. But yeah, that's how we checked it.
Thank you.
Sorry, so Mathieu has a follow-up question. Did you exclude answers suggesting that some people did not have PCD? For example, the paper that focuses on SARS-CoV-2 infections or the face mask, we didn't. We included all. However, we are working on projects where it's more important to know specifically who had PCD, and there we would exclude those where it's not where it's not pretty sure definite. Yeah. So it depends on the research question that we work on.
Thank you. And Bernhard has a comment or forwarding a message that he saw yesterday in the German Facebook group, the PCD family support group. Someone saying, "Panic, my little PCD kid has COVID. Me and the dad as well. He's almost 5 and got 2 vaccines already. He's feeling okay and have no obvious symptoms. We discovered that by chance when we wanted to visit grandma and did rapid tests. Did someone's PCD kid have COVID already? Is there something that we need to do so it will not get worse?" And he says that in answering such a post, it is very helpful to refer to your results of the study, to your web page with all the reference, that it is a huge help, and I completely agree with that.
That's very cool that it's useful. Of course, it also shows that there are still people who don't know about the study, which is a shame, but yeah, we can't reach everybody, but at least it has its purpose, and that's very cool.
Yes, indeed, we can't reach everybody, and it's also good that Bernhard, he's very active in these groups and makes very good comments and answers, and leading people to good sources of information. That's excellent. And so far there are no more questions from the audience. Maybe a question from me. So Eva, looking back from the very beginning, how things started and how you set up this study, this database in such a short time, and how things developed and how you adapted even to changing circumstances of the pandemic. Is there anything that you would have done differently when you look back now, or if you would have like changed things or adapted things differently?
Yeah, that's it's a good question. Of course, I'm not sure we actually, I'm not sure we could have done many things differently at the time. But for example, the questions about severity that we have are maybe a bit unspecific. The problem was that when we set it up, there were quite little information about typical symptoms and severity, and no other studies had suggested how to ask this in a questionnaire. So that would maybe be good to have different questions, but again, they didn't exist at the time. And you also can't change the question in the middle, because then you can't compare over time. So that makes it difficult, but that would be one thing that maybe we could have changed. I also recently realized another mistake, that with the branching in the questionnaire, we made a mistake early on, but now it's too late. However, the only thing is that in this study, we can send out these extra questionnaires. So it might be possible, for example, for some of the questions that we might not have good enough information, we could send out that in a special questionnaire to get more specific information. So at least it has good options to still, yeah, get more information.
Thank you. Katie, do you want to take the audience question?
Yes. So Ileana says, taking into account that Facebook is indeed the best communication tool for patients, are you thinking of creating a private Facebook group, not specifically for this study, where patients from each country will be able to join? Because as far as I know, the most active Facebook group is the German, but patients whose mother language is not German can't really be profited.
It's actually not a plan. The thing is also that this is quite time consuming to be very active. Already the website takes quite some time for us. And it wouldn't really be feasible, I think, to be able to have that. So I really think it's better that people within the network have that themselves. But yeah, I don't know, maybe Mirona has a comment for that.
Yes, I have a comment that it's not related to the COVID-PCD study, because this was discussed. We had a BEAT-PCD meeting with the representatives of the different European support groups before Christmas, and we discussed what would be the best platform. And it is true that many groups are very active on Facebook, but also many, especially younger patients, not children, but like teenagers or young adults, they are not. And in the end, they decided that a common group cannot really be very helpful, as a lot of patients are already active in different groups. And if this happens, it cannot come from us, from the BEAT-PCD network and from the researchers, because then it could be used also as an opportunity for the people to ask. I saw Matthias' comments on the chat. We don't want this to be used as an opportunity for people to ask clinical questions, management questions, because there are a lot of differences on the way PCD is managed between countries, and there is not a correct way to say that this, what is done, for example, in UK is right and what is done in Switzerland is wrong. So we want to avoid being active in these groups. I think it's important that these groups remain for the patients. Of course, if this, what we can do is offer the opportunity for patient representatives to discuss in meetings organized by us and decide if this is a good idea and they want to take it over. Yes, the Bernhard says in the chat, and this is very correct, that the PCD Foundation group, that it's from the US support group, it's quite active with many patients from all over the world and already exists. And I know that a lot of European people are also joining that, which is in English, and I guess a common group anyway would most probably be in English.
Thank you, Mirona, for your input. And just for the ones watching the recording wondering why we laughed, Mathieu said to reach teens, I want Mirona to start a TikTok channel.
Matke is younger than me, so he can do that, I think.
Yes, leave it to the youngsters, right? And not so young, sorry, he says. And maybe just something from me about the teens. I think reaching teens is rather difficult everywhere because it's an awkward age for them. And when I talked to one PCD teenager, she actually told me that she has some kind of, I think, WhatsApp group among her PCD teenage friends that she found on an online game, actually. And she rather preferred staying within her group instead of having an official PCD teenage platform chat or something like that. I think this is just, yes, the awkward age, and then things will change anyway when they grow older.
Makes sense.
And any questions from the audience? Maybe just one final question from me, Eva. And since you set up this excellent study in such a short time with so much participation from participants and questionnaires and even follow-up questionnaires, do you think that this model could be working in other diseases, or do you think that this excellent participation rate is also because PCD is a rare disease and participants are just happy to be active in this rather rare neglected disease?
I am sure that these people who participate in this study are more interested to participate than maybe in areas where there are more studies or more research. I think because there is a lot of research in PCD, but there are not that many studies where participants complete directly, and this is, I think, one of the reasons that that there is so high participation and relatively few drop out when you think about it. But I think it could also work in other rare diseases. But for example, yeah, CF, it's not that rare, but I don't think it would work as good there. I think that there has been so much research that people are maybe less interested to participate. I don't know, but I think it could work with other diseases as well, but mainly, I guess, rare diseases.
Can I add something?
Yes.
I think it would not work very well with common diseases because people are not engaged with support groups. I think in CF, maybe it's not the best example because the support groups there are very active and they reach a lot of people, maybe even more than PCD. But with something like asthma, for example, where most of the people who have asthma, they are not engaged with any support group, this will not work well.
But they also, at least that's my impression from the PhD, that parents of children with asthma, they have filled in so many questionnaires that they're tired, I think.
Yeah, that's correct. That's my impression also.
Thank you both. And Katie there, do you see any questions? Oh, yes, Sina popped up.
Me to read it?
Yes, please.
Would you consider adding a question of whether the participant may be willing to be reached in a future study about PCD? That might be a good option for different studies in the future.
Yeah, that's a very good suggestion. I will take that to the others and discuss it. I think that's a good idea because we have email addresses, and of course, people can then decide themselves if they want to reach out to another project like, I don't know, maybe they could get news of whether there are other studies where it's possible to participate. But of course, we don't want to push people, but let it be up to them. I think that's a good suggestion. Thanks.
Thank you for answering. Yes, that was a very good point, Sina. Katie, I think we got all questions, do we, and comments?
I believe so. So thanks again for an absolutely fantastic talk. It was so clear, and it's great to see how researchers and patients can work together and in a study as big as this. So I'll stop the recording here.